I want to thank everybody for coming out today. Today we're actually going to talk about an interesting topic that seems to be getting a lot of buzz, and that's the regenerative medicine revolution. And we're going to be talking about it related to specifically PRP, Wharton's jelly, and cord blood. My name is Dr. David S. Leidick. I am a chiropractor here at InnovaMed. And our other providers is Nicholas Isbell, who is our nurse practitioner, and our collaborative medical physician, Dr. Henry J. Van Pala. We are a medical practice that is integrated, working together to help offer solutions for you. Now, as a chiropractor, I'm the one giving this talk today, and there's a reason for that, because I have over 20 years experience working with chronic degenerative conditions. I see it day in and day out. So if there's anything that's chronic and degenerative that I haven't seen, there's nothing out there. I've seen a lot of different things, and I have been able to offer a solution to some of those conditions using chiropractic care. But as we have found out over the years, we're limited in what we can do at times for our patients. So I joined InnovaMed in 2018 to be able to offer that service in an integrated setting. Because I truly believe the way the healthcare field's going, the more integrated that we are, the better help that we can do for our patients working together. InnovaMed is truly an integrated practice. It is based on results driven, and based on that, we are looking at an integrative team approach made up of a medical doctor, nurse practitioner, chiro, rehab exercises, along with weight loss and nutrition, offering solutions to help you regain your life. Now, we're a true integrated practice working together under one roof. That means multiple licenses taking your information. When you come in and see your medical provider, it's not only are he taking that information and spending time with you, but we sit as a team bringing information to the table of how we can help you get the results that you're looking for. So it's multiple minds working together for you to get the results that you're looking for. So before we go any further, I want you to understand that our purpose is to help as many people as possible. It really breaks down to helping people with shoulder pain related to rotator cuff injuries, bicep tendon tears, joint degeneration, elbow pain, chronic elbow like tennis elbow, golfer's elbow, hip and back pain, specifically failed back surgeries. Failed back surgery is actually a syndrome. They actually call it failed back surgery syndrome. And there are things that we can do to help people who have had surgery who are still dealing with chronic pain. Knee pain, which is common. We see a lot of mild to moderate arthritis, meniscus tears, and other types of ligament tears, and foot pain. We see a lot of plantar fasciitis. And there's things that we can offer for patients with that. I know with plantar fasciitis specifically, some of the amniotic products that we will be talking about later on, or PRP, is a great resource for helping people with chronic plantar fasciitis and, of course, arthritis as well. So before we go any further, I like to kind of talk about the idea of how healthy is our country. If I was to poll everybody in here, and I'm going to ask, how many of us here think that we live in a healthy country? And I don't see a single hand. And I would agree with you. But let's talk about the statistics that go into why we feel that way. U.S. makes up approximately 5% of the world population. It's actually 4.8%. And that's where we are here in this world. We spend more in that 5% than the other 95% combined, which is startling. And out of that, we consume 75% of the world's medications. So if we consume 75% of the world's medications, we spend more than the other 95%, how come we're not a healthy country? So I'd like to introduce you to Barbara Starfield. She's a medical doctor who originally is from New York. She became the department head of Health Policy and Management at Johns Hopkins University. And in 2000, she designed or written a report that was basically on the effectiveness of American healthcare, and it was published in the Journal of the American Medical Association. Barbara Starfield was actually a pretty a very big player when it came to advocating for primary health care. And she wrote many books on the primary health care doctor and their management of patients and how they needed to be the central role of that. And she was also very big on the proponents of keeping patients safe. This study was designed or looked at because she wanted to see how effective our healthcare system was related to safety. And one of the things that she found out was she came up with what she determined based on this study, the third leading cause of death in this country. Third leading cause of death in this country is based on medical treatments. Now, let's talk about the numbers that were associated with this study. 106,000 from the side effects of properly prescribed drugs. That means you went to your doctor thought that drug was good enough for you, and you were able to take it, but still had a reaction too. 80,000 from hospital-caused infections. That means you went into the hospital, had a procedure done, and then just got a secondary infection because you were in that environment and happened to not be able to compensate for it and passed away. We are dealing with 12,000 from unnecessary surgeries, which means that patients are going in for elective surgeries that they probably should have never gone in for in the first place and happened to die because of that. And then she was able to link the rest together for medication errors because of physicians that are not talking to one another, or people doing polypharmacy because somebody's designing one drug for, or it's like could be an intern in the hospital, prescribing one drug and then the other physician's not aware of another drug. And this happens all the time, but it's the communication errors related to medications. And then, of course, 20,000 from other errors that are seen in the hospital. It's a very startling statistic. So in 2013, the U.S. was actually compared to 16 peer nations. So we took the 17 highest paid nations in our world and highest income nations in our world, and in that study, we wanted to see how effective the U.S. was compared with 16 of the other countries. And in this is what we came up with from the statistics from that. Out of all 17 countries, the U.S. came in dead last again. And it came in dead last related to these categories. When it came to overweight, the U.S. came in last for being the heaviest country. We're 35 pounds heavier now than we were 30 years ago. And we continue to get to be an overweight nation. Our body mass index is getting out of control. We know from the research and the studies that if you have a high BMI, you actually have an increased risk of cancer. It leads into diabetes, which again is probably why diabetes comes in. We come in dead last on that. It can lead to cognitive behavior issues in the future, such as dementia. Body mass index is one of those indicators that they use to determine how healthy you will be if you continue the course that you're actually going. I was very surprised on infant mortality. We come in last among the other 16 nations. And the probability of dying between the age of 15 and 50 years old, we come in 17th place. Does anybody know what is the number one leading cause of death under the age of, say under the age of 50 right now, and say between the ages of 45 and 50? And it's opiates is what's taken so many folks every year. So like I've said in the beginning, we have an opiate crisis in this country, and the whole approach and purpose of our integrated practice is to combat the opiate crisis, to provide solutions and other ways conservatively of helping people get off chronic pain management, unnecessary surgeries, and steroid use. So this study was named the U.S. Health Disadvantage. You can look it up. It's actually a study that's out there online, and you can look up the more information related to that study. So I always like to talk about the disease timeline. It's amazing how over the last 20 years, our perception of our health is based on quite honestly how we feel. So over here to the left, this is actually the start of a disease process. And can anybody tell me what happens on the other end of that spectrum at the end of the disease? And you're right, it is when you die, right? So if we know that this is the start and the end of the disease is when you pass away, when does symptoms usually appear? So let's talk about the number one leading cause of death in this country right now, cardiovascular disease. Approximately 600,000 people a year currently pass away due to coronary artery disease or some kind of event. Approximately half of those folks, 300,000, all had the same common first symptom. Do you know what that first symptom was? The heart attack that killed them. How many of us in this room know somebody who's had cancer and didn't even know they had cancer until they were diagnosed with it, and the symptoms, literally just came on within a month or two of them finding out they had cancer, and when they did the evaluation, they had a huge tumor inside their body. See, symptoms are not a good indication of how healthy you are, but we base our healthcare system on how we're feeling. You go to your doctor, you feel a certain way, you get a medication that counteracts that symptom, and if we feel good, then we must be healthy. And that's not the case. And so our mission, as well as the things that we talked about in the beginning, is to kind of change this perspective and concept that it's your health care is not based on how you feel, but it's about being proactive, identifying things that could potentially be issues going down the road, and working at doing our best to counteract the outcomes that could happen if we neglect our health care. So symptoms are a poor indication of how healthy we really are, and they usually do end by coming at the end of this disease timeline. So let's talk about inflammation. This is another misconception a lot of people have. If I was to say inflammation good or bad, how many people in here would say bad? Most of us do. But I would say today, inflammation within a short period of time of an injury is actually a very good thing. Inflammation is your body's way of repairing a situation that was injured. And part of that inflammatory response is that platelets go to that area. Those platelets reproduce and bring in growth factors and things like cytokines and other things that help the remodeling and the regeneration or healing of that tissue. So inflammation in the beginning phases of an injury is very, very important to you getting the results you're looking for. But a lot of us will take NSAIDs for long periods of time, and I would like to say that NSAIDs such as ibuprofen and naproxen long-term is the anti-healing drug. You are inhibiting your body's way of actually helping you heal. Let's use for an example lateral epicondylitis or tennis elbow. I would argue that that's truly not an acute inflammatory response, because if you've had it going on for months, you're probably looking at a tendinopathy or some kind of chronic pathology that's been going on for quite a while. And the longer you keep taking the NSAIDs, you're slowing your body's ability to take care of that. So it's really important to understand inflammation and in how that relationship is to the soft tissue around it. So now we have inflammation that's going on, and that can affect actually the movement of that joint. So let's talk a little bit about how a joint's movement or restrictions can either cause it to be healthy or unhealthy. So let's talk about this picture over here. We have two joints that are articulating with one another. We have this yellow part right here, which is called hyaline cartilage. It's the articulation that these two bones come together and move on. This blue area right through here is actually called synovial fluid. The synovial fluid is actually the median in which nutrients can actually cross and get to other parts of the bone. If you notice here, there's no blood vessel that goes into that joint. If we had a blood vessel that went into that joint, it would actually cause it to bleed out, right? Because when you move that joint, you'd be affecting that blood vessel. But we need nutrients to the bone and the connective tissue. So how do we really get that? The only way we can get the nutrients to the areas of that bone that we need is actually through movement. So as nutrients and blood supply come into the periosteum or the outside of the bone, they actually go into the synovial fluid, and through osmosis or osmotic pressure, the movement of that joint actually moves the material of nutrients into the bones. So a healthy joint is a joint that's actually moving. You can take that joint and restrict it and not move it for a period of time, and that joint becomes dried out, doesn't get the nutrients it needs, and actually will develop arthritic and degenerative changes based on that. This is a very important piece to understand when it comes to chronic degeneration, because you have to find out where this all originated from. It's very surprising to me when I bring patients in and we show them their films and we see arthritic changes. It's always the first question, well, how did this start? I didn't have the symptoms until maybe a couple months ago. But when we look at the x-ray, the evidence shows that it's been there for more than 10 years. Again, symptoms don't always equal where we are, right? But when that joint becomes restricted, it leads to these chronic degenerative conditions, and that could be caused by an old injury, repetitive stress, just abnormal wear and tear through life. So we could say then if a restricted joint is unhealthy, then a joint that's in movement can actually prevent arthritis. Because if we can keep joints moving, we're slowing down that progression. We're actually improving the health of that joint. So let's talk about one way that we can actually get an injury to a joint that can actually affect that long term and become an issue. And I always like to start with motor vehicle accidents. If we go back to our physics years, we can actually look at this equation of F equals m times A. F equals force, and that's equal to the mass of something, which is the weight of it, times the acceleration. So we'll use an example of this gentleman who's getting on a horse 120 years ago, and he was riding the church, and he's galloping along at, say, 20 miles an hour. And all of a sudden that horse, for whatever reason, trips, knocks him off, and he now at 20 miles an hour is flying through the air. Now, he weighs about 200 pounds. He's flying through the air, so his mass is 200 pounds, and he's going through the air at 20 miles an hour. What kind of force is he hitting that ground at when he lands on his left shoulder? About 800 pounds of force. So that 800 pounds of force, or excuse me, 8,000 pounds of force, excuse me, my math was off, 8,000 pounds of force is going to be hitting that shoulder. Do you think that would break his shoulder? Absolutely. So now let's take it to modern day times. We now have this gentleman who got out of this car who was hit from behind. And most cars, let's just say it weighs about 4,000 pounds. And so 4,000 pounds and a car hitting him at 20 miles an hour, you're looking at 80,000 pounds of force. Well, that 80,000 pounds of force didn't directly affect that person's body like it was when you were thrown off the horse. But that 80,000 pounds of force now was directed and bounced everything around inside that car, affecting this gentleman's neck. And if you think about it, the only thing that's not buckled down in a car is this 15, 20 pounds of your head floating through space. And as you can see here, this is a typical whiplash type of injury where you're hit from behind with a certain amount of force, your neck is whipped back to neutral, whipped into flexion, and then back to neutral. And during these whipping actions of extreme extension or flexion is where you can get ligament tears. Now, once you get those ligament tears, the inflammation phase starts to occur at that point. So if this patient was in a motor vehicle accident, he goes to his doctor, he gets checked out, they looked at his x-rays, and based on his x-rays, he didn't see anything wrong, and they said, you know, Mr. Jones, you have a sprain strain injury, and we call that whiplash, and you know, in the next 2 to 4 weeks, you're going to start feeling better. Use ice for the next 24, 48 hours, and then you can move over to heat, and if it doesn't get better, we can try using some NSAIDs, and we can do PT later on. In most cases, those patients resolve. They get better. But as time goes on, if that force of that car just slightly change the movement patterns of those joints, or those joints start to become restrictive. Remember what happens to a joint that's becoming restrictive? Doesn't quite move right, and that doesn't get the nutrition that it's looking for. There's different phases that a joint will go through over time. So even though he healed up from that accident, but the mechanics and movement patterns of those joints weren't really resolved, the body does what it can do for itself, but it does the best that it can. So here over here is a healthy joint, which is a normal vertebrae related on top of each other with a nice thick disc space. And you want to see nice fluid or hydration in that disc, and a nice yellow part up here, nucleus pulposus, which is the center of that disc. And this is a healthy joint that has not been injured. So what can happen, excuse me, over time, with time, that patient, same injury, could actually cause that disc to start to desiccate. So what happens over time, as the joint doesn't move properly, it starts to dry out. Some micro tears could have occurred to it. The nucleus pulposus starts to dry out. It starts to become a little bit thinner. We may or may not have symptoms related to that. We might start off with symptoms of maybe just neck tightness. But over time, that's phase 1 of degeneration. As we get down to phase 2 is where we start to see patients coming in the practice with related to injuries that happened years ago. They're having symptoms of, chronic pain or acute pain that maybe just started last week. And when we bring them in, this is the x-ray that we're looking at, and it just, changes the perspective of what they're thinking. When they come in, they're like, well, how did this happen? I just bent over the other day and my neck's in acute pain. And then when we look at the x-ray, we see all this degeneration. It's because of that old injury that never really was resolved. And as time goes on, that disc dries out. It becomes thinner and thinner. The bones will start to build up calcium deposits around it. And because of abnormal forces that are being placed on that vertebrae, it's based on Wolff's law, the body will counteract that force by growing bone. And so now the joint becomes even more restrictive. And as that joint becomes more restrictive, you lose mobility. As that mobility changes, you get more inflammation and more pain. And this is where we start to see symptoms. This is where we start to see people coming in our office. Unfortunately, the medical side of everything is we just treat the symptoms of this, but we haven't addressed the mechanics of it. And then down here on phase 3, we're looking at pretty severe degeneration, not only in the disc and joint, but not a lot can be done with those folks at that time. And usually it's it's pain management or surgery at that point. So let's talk about what a typical treatment cycle would actually be like if you went to your doctor, and we're going to use the example of a knee joint. Now, it could be a knee joint. We could use this as an example of a hip joint or a vertebrae. I'm just using arbitrarily the knee joint for an example today, because the protocol of this is fairly similar. You go to your doctor, and in most cases, you're going to get some kind of NSAIDs for inflammation. If you go back over a period of time and it doesn't seem to get resolved, you may get more or same of the same drug, or it may change to more of a prescription strength type of NSAID. But as times go on and that doesn't improve, then we bring you back and we get films. The x-rays can tell us a lot about what's going on to the actual bone material, like we showed you on this vertebrae that we showed you on the few slides earlier. It gives us a better understanding for where that chronic pain and inflammation is occurring. From there, the typical treatment protocol is using corticosteroids. If that doesn't work over time, you're back getting MRIs. And from MRIs, that's either going to lead you up to an epidural steroid injection, or if it's related to a joint such as your knee, you can only do so many cortisone injections. You're looking at arthroscopy at that point, and then another surgery, possibly. And again, doesn't always fix the problem, and you may end up back with joint pain again. So this is kind of the cycle and protocols that most people go through related to their conditions, and some of you may relate to that because you've already gone through some of this. So let's talk about NSAIDs, because we have the ability to just buy NSAIDs over the counter, and I really feel it's a drug that's being overused in this country, and it's hurting a lot of people. So NSAIDs are medications that we can use to alleviate pain at the nerve level. It helps by lowering that pain-causing inflammation at the site. But these drugs do not address the cause of the situation. They don't address the cause of the tissue damage and the connective tissue that's associated with it. They do not regenerate anything. They just help by eliminating the signals that are going to your brain. And NSAIDs have been linked to ulcers. A lot of us know that. But it's surprising to me how many people do not realize that long-term NSAIDs can lead to heart attack and strokes. And I had a family member who took too much NSAIDs for too many years and had a heart attack as one of his indicators. So we have an issue with NSAIDs in this country, and when you're taking long-term use of it in high doses, you are increasing your risk of heart attack and stroke. So let's talk a little bit about cortisone injections, because everybody gets them, and it seems to be the main thing that people do when you go to your doctor and you're not a surgical candidate yet, and they're going to say, okay, well, you're having all this pain and inflammation, the next thing we can do is we can do an injection of cortisone in there. But let's talk about what cortisone actually is and what it can do. Cortisone actually breaks down scar tissue. It can actually melt it away. It's a very important drug for degrading that. It degrades actually bone material and cartilage over time. Not many people are aware of that. It can worsen or actually speed up joint degeneration, and it's only temporary. It doesn't last very long, and if you go back to doing your normal activities, you just stand a chance of increasing that problem from, you're really not prolonging it, you're just buying time before the situation comes back again. And it can worsen systemic diseases like diabetes, and it can only be done 3 to 4 times max per year because of the degradation it can do for bone material and soft tissue. It's a great drug for knocking out inflammation. Let's be honest. If you got a house that's on fire, I mean, you come in there with a water hose, you're going to get the fire knocked out. It's kind of the same way with cortisone. It's going to come in, it's going to knock out the inflammation, but it's going to come with a wake of destruction, just like that water hose going through your house is going to come through with a wake of destruction. So we need to know what cortisone really is and why we don't really want to use that long term. Hyaluronic acid is actually a very good option for helping with knee degeneration. It can lubricate that joint. It does not grow new cartilage, so you need to be aware of that. It's a natural substance that actually comes from the rooster cone of a rooster. It's very safe. It's covered by most insurance plans. You need about 3 to 5 injections, according to the FDA, to be beneficial. It's loaded with hyaluronic acid, which is like that WD-40, that lubrication that you need for the joint. It buys time, but doesn't prevent you from having knee surgery in the future. It's just a short-term tool that we can use for relief, but not a lot of downsides to using it. So let's talk about surgery, because eventually, if all these other options don't work out for you and you're seeing your orthopedic doctor, you got to remember they're surgeons. This is what they do, right? So if they have exhausted all of their conservative methods of helping you and you're getting to a situation where you're almost bone on top of bone, then they're going to be pushing for surgery. So some of these slides are a little bit graphic, but I want to share with you what surgery is in the different aspects of it. Here's a typical arthroscopy to a knee. You see these probes that are actually in there. And through that procedure, they can actually trim up meniscus and take out material that they actually need to pull out. Over here on the right, you will see a total knee replacement. And you're only allowed to do so many of those in your lifetime because they have to cut bone in order to put these prostheses on. So it's a pretty involved procedure, but that would be a total knee replacement. And over here, we're looking at the start of hip replacement. One of the biggest things about having a knee and hip replaced is the painful rehab in the months. That's probably the hardest part of having these surgeries is the rehab that you have to go through to get that range of motion back, and it just takes months. It's not uncommon for you to put 6 months into a situation like this to get back to where he used to be. So it's not a quick fix. Actually, the rehab can be some of the hardest things that you have to go through, but it's very important to get that range of motion back so your outcomes in the future look really good. And as we know, going in for an elective surgery, there's always complications, and here are some examples of what complications can arise from, such as having infections. So now let's talk about what this regenerative revolution is all about, because I really know this is what brought you here today, and I wanted to give you a little bit more of an understanding prior to me getting into this regenerative revolution, so you understand why this is so important to us. We're talking specifically about stem cells. Stem cells are the precursor or the basic stem plate to all cells of our body related to tissue, bone, tendons, glands, and organs. Stem cells can actually replicate into muscle cell, skin cells, bone cells, tendons, organ, nerve, and it can replicate into other stem cells, which is really neat. So stem cells are that basic precursor which helps the regenerative process. This little guy over here is a mesenchymal stem cell, and these little tentacles you see coming off of it are called telomeres. And they're very important because that's how your stem cell actually communicates with other stem cells, or it gets the information that when you're having an injury in your body, that it knows where to go and when to act on an area that needs repair and regeneration. Mesenchymal stem cells specifically are basic connective tissue stem cells. They form that framework like we talked about with organs, nerves, skin, muscles, and ligaments and tendons. But is one of the things that we use here the most related to osteoarthritis and cartilage repair within joints. Another type of stem cell that you will actually see out there is hematopoietic, say that one twice, stem cells. And hematopoietic stem cells are found more in the cord blood, and they are made up of red blood cells and white blood cells. And then the main function of hematopoietic stem cells is to actually produce other types of blood cells. So let's talk about Wharton's jelly. Wharton's jelly is the material that is found in an umbilical cord. It is wrapped around the umbilical artery and vein. It is the richest source of mesenchymal stem cells in the body. And the baby utilizes that during the growth and development of that fetus. It is all encased within an amniotic membrane, and that's the barrier that protects the baby from the mom's immune system. So everything inside that amniotic sac is immune privilege. Being said, immune privilege means that the body cannot attack that. So any material from this Wharton's jelly that's injected into another patient is immune privilege. So there's no worry or concern with having a body reacting to that material. Wharton's jelly is that protective layer in the cord like we talked about, and is the richest source of mesenchymal stem cells. Cord blood brings benefits to the table related to growth factors and other types of cytokines and hyaluronic acid. When we use amniotic fluid, for an example, or other types of cord blood samples, we can actually increase the effectiveness of regeneration at that level related to the materials needed, like growth factors and cytokines and hyaluronic acid. Those are like the things that are necessary to prime an environment so that when stem cells come in there, they can get the most benefit. And the reason why we bring that up in here is because the company that we use offers many different products. Part of that is some products would have more hyaluronic acid and growth factors that don't have stem cells. And then, of course, one of their products is, just 100% stem cells. And we have the ability to be able to manipulate different parts of that together for the patient's need, because we may need to have, stem cells for regeneration, but there's such an inflammatory response there. By bringing in some of the cytokines and growth factors, we can actually work on that as well. So it's important to understand the difference between cord blood and Wharton's jelly. The research goes back over 100 years. There's a study here that was produced in 1913 from a doctor from New York. His name was Maximilian Stern. And what he did was he took amniotic tissue and used it on burn victims and saw that he was actually getting better results using amniotic tissue versus skin grafts. And he found that that material was very smooth and glossy. And that we kind of link back to the early stages of regenerative medicine. And as you can see, there was an article written about that in 1913. So let's talk about PRP. PRP is one of those products and one of those procedures we actually do in our office. PRP stands for platelet-rich plasma. It's been around for probably over 20 years. I know even in the area hospitals and a lot of orthopedic clinics are doing PRP. The whole premise behind PRP is to be able to take a person's blood. We draw 50 to 60 mLs of blood off of you. We take that blood and we spin it down at various RPMs, and we get that coat of platelet-rich plasma. We're looking for a concentration of platelets in there. And as we extract those platelets out, we can then inject it into an injured joint. And when we do that, it promotes the growth factors and cytokines that we talked about, which is that inflammatory response that signals to the body, hey, we got an injury here, we need to come over here and try to work on healing that. So PRP is like a first generation regenerative medicine thing that's been going on for a while, and we have evolved since PRP into more stem cell therapy. But PRP offers a lot of benefits, especially to our younger people that may not need stem cells, but there's no reason for a young child here to be on an opiate. So if they're coming in from a sports injury, PRP is a great option for helping for healing and repair and to getting inflammation under control. And PRP has also been very beneficial working with people with, say, plantar fasciitis and other types of like medial and lateral collateral ligament injuries or sprained strains. So we talked about cord blood, Wharton's jelly, and amniotic tissue. We actually use a company out of Utah that specifically works with these products, specifically the Wharton's jelly. This company is FDA cleared. What that means is they have gone through stringent requirements to keep the public safe. And I think it's FDA Section 365 that actually they have to follow certain parameters and guidelines in order to be able to sell their products and meet the requirements of safety in our country. So the product is FDA cleared, or the company's FDA clear, but the material that we use is not FDA approved because it's not a drug. So you need to understand that. It's donated by healthy moms after a healthy live birth. These moms have been tracked through their pregnancy. They have been screened. Their health histories have been looked at, and they're donated by them after a live birth. And the placental tissue and fluids are processed in a clean room that exceeds the standards of most American Association of Tissue Banks. And all material that is quantitative and put together in vials for injection is confirmed. The validity is confirmed by counts through a third-party source. And I know they're using a place in Atlanta, Georgia, that does some of their counts, and then the University of Utah does some of their work as well. So every lot that goes out, it's being checked and validated for its concentration and counts related to stem cells. So we're very proud of the company that we use when it comes to the products that we're offering. And we feel that this company that we use offers many different solutions for most people's needs. So regenerative tissue, we're looking at stem cells and tissue building blocks. What is tissue building blocks? The growth factors, the cytokines, all the things we talked about related to hyaluronic acid. With combination of stem cells, we can then inject that into an injured area, and the theory is to regenerate tissue, stimulate repair, and help your body help itself. And the research continues to go on, showing tremendous benefits to stem cell therapy. And I know even locally in the area, we have some universities here that are still doing research on stem cell therapy. And I want to say, when I was at one of our last seminars, I think there was over 12,000 active studies going on right now in 2018 related to stem cell therapy. And you're going to see more and more information on biologics and what they can do. And we really feel like this is the way the future is going for healthcare. So let's talk about what the in-office procedure is all about. So if you come in for a typical joint that's going to be injected, it's a 1-hour procedure, and most of that time is just evaluating you afterward to make sure everything's okay. There's no anesthesia, hospital stays, or antibiotics. It's 0 recovery time. Clinically, we expected significant improvements in function within 1 to 3 months. I would actually push you out more towards the 3 months, and I'll explain that to you more towards the end, because it takes time to regenerate tissue. So some of the products that we put in with the stem cells could get you some immediate relief in the beginning, but the long-term benefits of stem cell therapy, you're looking at a minimum of 3 to 4 months before you really start seeing the benefits of what it can do, and those benefits can go all the way up to 8 months. There's minimal adverse effects such as fever, injection site aches, swelling. There's really no downside to this. And I want to say, out of so many thousand injections last year, there was only one reaction, and it had nothing to do with the stem cells. It was all based on improper cleaning of the site prior to the procedure. So it was more of the technician error than anything else. So we feel that we're dealing with a product that's very effective, very safe, related to some of the other options you may be given out there that others feel is very conservative. So I'm going to share with you some patient stories. These stories are not to be said to you that these are what's going to happen to you. These are just to give you some hope. These are actual patients that went through these procedures and wanted to share their experience. So I chose 2 to talk about today and kind of elaborate a little bit more on that. First patient came in, she was 43 years old. She had debilitating right knee pain. No history of any specific trauma. She was a runner over the years, but as the years have gone on, she has been having a hard time going up and down stairs, specifically the last 2 years. And at one point, she had to go up those stairs sideways to get up and down. Stopped all exercise 6 months prior to her pain, and ligament tears were noted in the knee joint with a history of arthritis. She went through the procedure. After the day of injection, 1 week after, she was able to start to run up and down stairs with minimal pain or discomfort. By 4 weeks out, the patient was able to do a squat and was feeling 80% better. And then at the end of 2 months, the patient described being 95 better, an improvement, able to exercise, and she was going back to doing some pain-free running. Pretty phenomenal results on regenerating some tissue, helping the body help itself to get back its life and mobility. The second patient is somebody that we know quite dearly, and she is a female, 54 years old, physical therapist that had debilitating bilateral knee pain. She had numerous knee dislocations by the age of 20. Over the last, multiple times, over 20 times over the years. By the age of 22, she was told that she would probably need a knee replacement by the time she hit her 40s and 50s. And as a physical therapist, she had seen the effects of what a knee replacement can do to patients and the downside to that and the infections and things that kind of go along with that. So she was determined that that was not going to be an option for her. She did all the conservative treatments such as rehab, nutrition, chiropractic, hyaluronic acid injections, all with limited relief. And so for the past 30 years could not even sit crisscross on the floor with her children. And she had difficulty going up and down stairs. So we injected 1 week after, she had mild inflammation in her knees. About 4 weeks after the injection, she was able to wear high heels at a 2-day seminar, which was a big deal. And she was able to do a full squat to get a case of water. And the story behind that was she was with her mother going to the store to grab some water. Before she even knew it, she actually squatted to pick the water out of the bottom shelf to put it onto the cart and realized, hey, I didn't do that before, but now I can do that. And then approximately 12 weeks after, she reported a success rate of 95%. And her quote, "It is strange not having anything bothering my knees." Pretty phenomenal history. So I share with you some pre and post x-rays now. Again, these are not to say that this can happen to you, but they're given to, again, give you some hope. These are actual patients that did see a change in their x-rays, and we want to show with you what that can do for you. In July 2016, we had bilateral knee x-rays done. You can see on the left knee, the lateral aspect of that knee is degenerated and it's almost bone on top of bone. You can see the significant change over here. In April of 2017, the spacing on that has grown quite a bit. Again, this gave that joint some life, and this is going to prolong surgery for a long, long time. Very good success story. We got another pre and post x-ray here. These are bilateral knee x-rays as well. The medial aspect of the knee is almost bone on top of bone, pretty much bone on top of bone here. And as you can see over here, the spacing that's starting to develop between those spaces that were sitting on top of the bone. It's not drastic, but it's enough. It is enough to take her pain away. It was enough to get her some life back in those joints, and again, to prolong the process of having to have surgery. So another success rate. Here's another set of x-rays that we took. As you can see here, this one's pretty dramatic. This was really significantly, the lateral aspect of that knee was bone on top of bone on the right knee. And as you can see between that x-ray and that x-ray right there, that is a pretty good opening that we see in that joint space. One of the ways that we get the results that we're looking for as well is we do these offloading braces. So when we inject the joint, we actually offload that joint so that we get the maximum benefit of those stem cells working in there. So if we could take the stress off of that joint, open that joint space up, it helps to bring that material in there and give it the best results. That's pretty significant. And of course, our last one here, you can actually see bone on top of bone over here on the left knee. And as you can see over here, there's a little bit of spacing going on in between that one as well. So some pretty phenomenal things that we see with regenerative medicine. The reason why, and I wanted to share this with you, one of the reasons why I am talking to you today is because I was a recipient of a stem cell injection. And my history goes back to having an injury to my knee joint probably about 10 years ago. And over the last 10 years, it's just progressively gotten worse. And in 2017, after a lot of thought and frustration and pain, you know, going through that model I told you about of all the different things that patients can do, I had my MRI and they found out I had a meniscus tear, and it was a full-length tear, and it was a flap tear. It was actually flipped up on top of one another, and it was locking and causing me some issues. So not knowing about regenerative medicine at that point, I did what my medical professional friends were telling me, and they're like, you got to have the surgery because you can't go around hurting like that. And the last thing I wanted to do is have my life being controlled by my knee. So I had the surgery in 2017, and the surgery went well, and I thought I healed up pretty nicely from it. But within a few months, the pain wasn't going away, and I have dealt with chronic inflammation since that time. And then when I joined InnovaMed at the end of 2018, and we decided that we were going to do regenerative medicine, I said, I'm going to be one of the first ones to get it, so that I can talk something that I truly believe in and have seen. And I'll tell you, the journey wasn't all that pretty at first because I was hurting a little bit in the beginning. But I can tell you by the time I hit the second or third month, it has made a significant difference in my knee. I don't have my pre and post x-rays to show you right now because I'm only about 4 months out. I'm going to wait to get those as time goes on. But it has made a big difference in my life. Where I was limiting my exercise as an activity of daily living, and now I'm back to cycling and doing things that I love to do. It's important for me to work out, and I wasn't able to do that before. It has regained some movement in my life, and I feel confident that I can go out and do things. Okay, so what we're going to now talk about is comparing the costs of regenerative medicine. And I just want to be really upfront with everybody here. Regenerative medicine is not covered by insurance. And the reason why I share that with you right up front is because you need to know that your insurance company doesn't care about your outcomes in life. And they want to always go to the cheapest route that they can go on. And corticosteroids is a very cheap option for them. And if that doesn't work over time and the joint's bad enough, they just go ahead and start pushing you towards surgery. But they will tell you that there's not enough research to validate it and all of those things. And in certain parts of the country, it is starting to be covered by insurance. But as of today, stem cell therapy is not covered. But I wanted to let you know that because I need you to understand the comparative costs here. So let's use the example of a knee replacement. If you're going in for a knee replacement, that knee replacement is going to cost between $25,000 and $50,000. There is an out-of-pocket expense that you're going to have to take care of. And that's usually co-insurance and deductibles. And it's not uncommon to see patients pay anywhere between $3,000 to $15,000. For example, with my surgery, I ended up paying $6,000 just to meet deductibles and out-of-pocket expenses. So you need to be aware of that because the money is going to be spent some way. It's going to be taken out somewhere either in deductibles or whatever it may be. Now, when you understand the comparative costs, you understand that there is money involved. Now it comes back to what is the safest and most effective outcome for you. So regenerative medicine in our country goes anywhere between $5,000 and $11,000 per injection. And that is, a range, and it depends on what is used and what different products are used for you. So that's the cost on average. It's really important to understand that we offer solutions for you to get your life back. And if cost is one of those things that is limiting you, we do have financial plans here available. We have multiple companies that we use to help patients get back to gaining their life again. And for the price of a cup of coffee every day, there is a way for you to afford to get this injection done. We've seen patients come in here and do it, and the results are showing for themselves. And, it is an investment in your future, but you can't go wrong in investing in your health and your outcomes in your future. And the more educated that you are about how health and wellness is derived and how you can maintain it is critical because you're going to be your first line of defense in helping yourself in the future when it comes to making decisions. If you're relying on your doctors and you're not educated about what's going on and you only do what your insurance is going to be giving you, you're putting yourself at risk. I plead with you on that because you need to be aware of that. We're in a society now where you have to question and you have to make informed decisions. It's part of the reason why I came out today to give this talk, because part of it is to inform you, to give you the resources available so that if you are interested in regenerative medicine, that you have the facts and that things that I brought up in this you can look up. And we would love for you to come in and spend time talking to us. We may find out that stem cell therapy specifically is not right for you, but we'll have another solution for you. But we would be excited to see you and to see how we can get you back on the road of health and healing. And as you can see, with the movement of that joint and the collaboration of the physicians here at InnovaMed, we are committed to helping you get to where you want to be. And our hashtag is basically to regain your life. We have innovative solutions to help you get where you want to be. So I thank you for coming out today, and we thank you for giving me an opportunity to talk to you about such an interesting topic, and we encourage questions at the end, and I look forward to seeing you in the near future. Thank you.